Welcome to the RSNA RadioGraphics podcast. I am Dr. Refky Nicola from SUNY Upstate Medical University and one of the assistant editors of RadioGraphics podcast. Today we are speaking with Dr. Purysko, who is an associate professor of radiology at the Cleveland Clinic and is author of the invited commentary regarding the recent article in the May 2023 edition of the RadioGraphics Journal entitled MRI of Benign Prostatic Hypertrophy. Important pre- and post-therapeutic considerations. Welcome to the podcast.
Thank you. Thanks for inviting me, Dr. Nicola. It's a pleasure to be here today.
So let's go over some things first. Can you define what is BPH, benign prostatic hypertrophy?
Sure. Yeah. So, this term is applied to a histologic diagnosis, and that refers to the proliferation of glandular epithelial tissue, smooth muscle, and connective tissue. So it's really a combination of these three components that lead to the enlargement of the transition zone of the prostate. So they call it stromoglandular hyperplasia. Not every patient with BPH will develop symptoms, and not every patient with symptoms will have BPH. But it's important to make that distinction because BPH by itself, it's almost part of the normal aging process in men, is extremely common. By the age of 60% of men will have it. By the age of 80% of men will have this condition.
What are some of the imaging findings that are associated with BPH?
Yeah, so that's a great question. Typically, we see the transition zone enlargement. The transition zone is really the central part of the prostate. It's important to distinguish that also from the central zone, which is a different part of the prostate. So the transition zone is the portion of the prostate that encircles the urethra. And what we typically see on imaging, besides the enlargement, we see on MRI in particular, which is the topic of this article, we see that there is a mixture usually of high and low signal areas, sometimes within encapsulated nodules. We might see development of nodules that extend inside of the bladder or even outside of the transition zone of the prostate into the peripheral zone.
So the article highlights several types of treatments. Could you take us through some of these treatments? The first treatment that they highlight is medical treatment. What are some of the medical options for patients?
Yeah, so that's a great question. And just to emphasize here that I'm not a urologist, so take my advice with a grain of salt here. So basically, the medical treatment, the first part is the conservative management. So there are some lifestyle changes, for example, fluid restriction or avoiding some medications that might have a diuretic property, for example. So that's the first step. And obviously, many patients will eventually need some kind of medical treatment with drugs. There are two, the most common or the more popular ones are the alpha blockers, which are typically affecting the smooth muscle tone, and the alpha reductase inhibitors, which is most commonly known as finasteride or dutasteride. They have different mechanisms, and basically the alpha blockers, they can help with symptoms, but they don't shrink the prostate. Really, the 5-alpha reductase inhibitors, these are the ones that have properties that can shrink the prostatic tissue and lead to some more long-term improvement of the condition. And in some cases, patients might actually have therapy with both medications. And there is data in the literature that shows that when they're used combined, they really reduce the chance that patient might develop urinary retention or even the need for some kind of surgical intervention down the road.
The article does highlight some surgical treatments. Take us through some of the surgical options that are available for patients.
Yeah, this is a field that it's really expanding. And that's one of the nice things about this article, because it really talks to us about all the different options, the newer options that are coming, even some that are even considered investigational. But the more traditional treatments, the first one is the simple prostatectomy. This is still performed usually for patients that have a very large prostate or when none of the other newer options are available, but really is more commonly used for patients that have large prostate glands, and basically they remove the transition zone of the prostate. So we see when we're looking at MRI, we look at what's called the surgical capsule, which is that interface between the transition and peripheral zone of the prostate. So the simple prostatectomy is basically removal of the transition zone using that line as sort of a reference. And then you have the simple transurethral resection of the prostate. That's another classic treatment that really became, very, very popular because it has less morbidity and mortality compared to the simple prostatectomy procedures. These are usually done, as the name says, through the urethra, and involves, debulking some of the tissue that might be causing obstruction.
Could you tell us a little bit about some of the emerging minimally invasive procedures that are available for patients?
Right. Yeah. So even before that, some of the more recent procedures, which are still considered part of the traditional techniques, for example, laser enucleation, I think that that's a very popular technique amongst urologists. It does require a certain skill set, but basically seems to be a very effective procedure where they come from the outside in and remove as much tissue as possible. So that seems to be a very popular option. And then when we talk about the minimally invasive ones, these are the ones that actually the patients can have done in the office. There is no need for general anesthesia or hospitalization. And these include procedures, for example, like the Urolift placement, which is basically those are metallic tabs that are used to stretch the prostatic tissue and open the prostatic urethra. And it's a good option, particularly for patients who might want to preserve sexual function, because all these treatments might lead to some degree of sexual dysfunction, especially ejaculatory dysfunction, not so much erectile dysfunction. But the Urolift is one that seems to be associated with lower risks of sexual dysfunction. And then you have also, for example, water vapor therapy that's called RESM.
What has been the most effective from your experience or what you've seen in the literature?
Yeah, so this is an excellent question, and here it's it's not so much about the effectiveness of the treatment itself. All these treatments they've been proved to be efficient in terms of reducing symptoms, but really the patients are triaged for each one of these treatments based on a number of different factors. One of them, for example, is prostatic enlargement. So there are certain procedures who are not indicated for very large prostates, while other procedures might be more effective in large prostates. The other thing is the risk that the patient might have. So, for example, patients who might have an increased risk of bleeding because they might be on blood thinners, for example, there are certain techniques that are preferred. The laser therapies, for example, are more commonly utilized for this patient. So, all of them have some effectiveness to some degree, but the decision takes into account other factors, including patient preference as well, with respect to their comfort level with certain risks. For example, as I mentioned, that the sexual dysfunction is one of them, and also the urologist's expertise. It's one of those things like, what's more effective? It depends on who you ask, because different
Right.
urologists might have different skill sets in different areas.
Should patients be screened for prostate cancer before treatment?
There is no formal recommendation. So the guidelines don't mention that, it should be part of, investigation or pre-treatment evaluation for BPH, that patients should get any screening. Imaging is actually, it's not necessarily considered, especially before a medical treatment. Sometimes they will order before any surgical treatment of these patients, but the formal screening for prostate cancer is not formally recommended.
What about the association of BPH with prostate cancer? Is there any association at all?
There is no established link in the literature. There are several articles who try to look into this. The quality of the evidence is not extremely robust. So there's no, again, like I said, accepted link. There are some papers that might, BPH might actually have a protective effect against development of prostate cancer, while others might conclude that there is some kind of link. What the literature has shown is that patients with BPH are more likely to be diagnosed with cancer, not because of the causal relationship, but because these patients usually have elevated PSA. And so that elevated PSA that comes with BPH might trigger a biopsy, which can result in a higher detection of prostate cancer, not necessarily clinically significant prostate cancer, but these patients might be diagnosed more often with prostate cancer just because of the PSA elevation that comes with BPH.
So I want to go back to how do these treatment options that we talked about, whether the surgical or the minimally invasive procedures, how do they affect the diagnosis of prostate cancer in the future for these patients?
Yeah, so that's another great question. And obviously, as we're using imaging now, all these treatments can cause some changes in the prostate that might affect our ability to see prostate cancer. And that's Dr. Elizabeth Ham did a fantastic job illustrating very well in her article, and I encourage everyone to go and take a look. But certain treatments, I would say that the medical treatments, which is probably the one that has been looked more closely, some of the medical treatments can actually decrease the conspicuity of tumors. This has been mostly studied in patients with low risk and or intermediate favor risk, so Gleason 6 or 7 prostate cancers. But really, there isn't any evidence that shows that our ability to detect these cancers on MRI is negatively impacted. In fact, there are a couple of papers at least that show that using PIRADS, which is more of a qualitative assessment of the images, there is not necessarily, again, established link with poor performance of MRI in this kind of patient population. We do know that, it affects not only the appearance of the cancer, it can affect the appearance of the prostate itself. One of the metrics, for example, ADC values or apparent diffusion coefficient, they can be changed with these therapies. When we talked about the medical treatments, then the surgical treatments, then things are slightly different. Some of these treatments can cause coagulation necrosis, especially the laser therapies, for example. If you image these patients very early on, some areas of the prostate might show restricted diffusion that could be confused with cancer. Some others might simulate the appearance of abscesses as well. Again, I encourage everyone to take a look at some of the nice images provided in the article. But this is typically more transient, usually goes away with some time. The one that has been shown to cause more problems is the urolift. Obviously, because we're putting a metallic implant in the prostate, and some of that can cause susceptibility artifacts. And it's not a contraindication necessarily for doing prostate MRI, but people need to be aware when that implant is present, because you might want to do a multiparametric MRI as opposed to offering a biparametric MRI for that patient population. In some cases, even if you have a negative MRI, it might be a good idea potentially to perform a biopsy if you can't see anything, because again, that could compromise our ability to see certain regions of the prostate, particularly the transition zone.
So it sounds like these procedures have to be taken into consideration as well as have to be known beforehand before these patients pursue an MRI.
Ideally, yes. And we know that not always that information will be available, but certainly if you have any kind of questionnaire to your patients regarding prior biopsy results or PSA levels, it might be worth including a question about prior treatment for BPH.
Well, thank you very much, Dr. Purysko, for talking to us. You can read his editorial comments as well as the entire article in the May 2023 edition of the RadioGraphics Journal. Thank you so much.
Thank you very much. It was a pleasure being here with you.